I'd like to say hello to all of you Pilates lovers out there and future Pilates lovers. Welcome to my show, All Things Pilates, and I am your host, Darien Gold. I'll be sharing with you my knowledge and experiences, and also giving you different workout tips and even exercises that you can try at home. Now, for those of you who have not taken the Pilates plunge yet, there are two main approaches to the Pilates method. The classical approach, which is geared around the original Pilates repertoire and is formatted with sets of routines with a clearly defined process of how a student progresses from the basics to the advanced work. Also, there is a lot of attention on body alignment and how these original exercises help to lift and straighten the body. This is achieved by creating the concept of a two-way stretch, no matter what position the body is in. The contemporary approach doesn't necessarily follow a set routine, but more focuses on what the student's needs are for that particular lesson. And a program develops which encompasses functional exercises and corrective movement, allowing, I think, a little more exploration in finding ways to develop healthier movement patterns. Over the last couple of decades, spin-offs and variations of the Pilates method have continued to evolve, and many schools and teachers have moved or are moving further away from the original teachings. For me, my goal is to sort it all out for you, and in that way, whichever approach you decide, which one will be best for you, you'll have made an educated decision when you're ready to start classes and take that Pilates plunge. I have a very special guest with me here today. Her name is Gwen Miller. She is an integrative Pilates instructor and educator and derives her work from the contemporary approach. She also treats various spinal pathologies such as disc derangement, spondylosis, stenosis, osteoporosis. It's a lot of osis, huh? And our topic for today, scoliosis. Further, she also treats post-surgical patients with rehabilitative movement programming for those who have had, for example, a vertebral fusion or a laminectomy. It's very, very impressive, Miss Gwen. How are you? Thank you so much for coming on to my show today.
I'm doing well, Darien. Thanks for having me.
It's so nice to see you. It's been a long time. I think the last time I saw you, you had a scoliosis workshop, right?
Yeah, I think that's right.
Before we delve into our topic today, when did you start Pilates? How did Pilates find you?
Well, it's an interesting thing. Pilates found me because there was a introductory level instructor training workshop at the club that I work out of, and I did it as a what the heck. I just said I've never done this before and it could be interesting and why not. And I began immediately to see how Pilates could be very accessible and useful in corrective exercise, which was what I was specializing in at that point. And of course, the first time I tried it in my own body, I was sold and decided that this was something that I was going to jump into with all 4 feet. And it's been a love story ever since.
Uh-huh. If only Mr. Pilates knew how many of us adore him and love him, I think he would be quite pleased and happy that we are taking his work forward. And one reason why I'm having Gwen as my first Pilates guest, last week I had a horse dressage trainer, Allison Matthey, and before then I had a chiropractor, Dr. Stephen Battolino, both bringing something very special to the Pilates world. because I'm classically trained and I've been teaching this work for over almost 25 years now, I approach the work based on the original teachings, and it's like the Dems and the Republicans, right? I want us to get along, and I have always sensed that people on the contemporary side and people on the classical side don't seem to have, I'm not sure that there's any love there. And I hope that through my show, I can bring on different kinds of Pilates instructors, both classical and contemporary, and we can help the public understand the versatility of this work and this global phenomenon that continues to grow, right? Don't you think it's growing? You see that in your work,
it's
too.
It's definitely growing, yes.
Getting back to the osises, can you explain exactly what scoliosis is?
Yes, scoliosis is a lateral or a sideways curvature of the spine. Normally, the spine has curves front and back in the neck, the upper back or the rib cage part of the spine, and the low back. Everybody has that. And what is different about a spine with scoliosis is that the spine now curves sideways as well. And this sideways curvature is nearly always coupled with a rotation as well.
A rotation depending on where the curve is?
Correct. So, say, for example, the curve is moving to the right side of a person's body. The vertebrae will be rotating so that the right rib cage will rotate to the back. And this is one of the things that becomes evident as the scoliosis in a larger degree curve becomes more evident, is that rib rotation back.
That leads me to my next question, which is how do you actually determine the severity of the scoliosis? Is there a special instrument or is it just a visual check?
Well, there are, yes, for both. The standard screening test that is hopefully still done in schools is the Adams test, and that is when the child or the person bends over and the practitioner behind them can see the soft tissue being pushed backward by the vertebra. And so that gives an indication of the direction that the scoliosis is traveling. There's an instrument that you can use to give you more information during that test called a scoliometer, and that's basically a level that you use to measure where those rotations and side bending is occurring. But as far as determining the severity, that in an X-ray, the standard is to have a doctor, general practitioner, a chiropractor, osteopath, to measure the angle of the vertebra at the beginning and end, if you will, of the curve going in one direction. They measure the intersection of the angle, and that is called a Cobb angle. And that's where you get a number such as 20 degrees or 40 degrees. That's referring to that angle of intersection in the Cobb measurement. And that is something that a doctor determines.
Before they would come to you, that they would come to you with that information?
Not necessarily. I've had many clients who had never had an X-ray, did not know they had a scoliosis. Actually, the National Scoliosis Foundation now says that scoliosis is not a diagnosis, it's a description. And so that frees up non-medically licensed practitioners to talk about it with their clientele. Although I would never want to tell someone that they had something that would be, not
viewed as something that's not right or good or
I think
healthy.
that would be something that would be out of scope, and I would not want to give a person a diagnosis when I'm not a medically licensed professional. However, when I notice something, I do say, your spine appears to be doing this. Did you know that about yourself? And then, the severity also, it's such an individual thing. Some people who have what's considered a very mild scoliosis will have a lot of discomfort with that. And some people who have a fairly large Cobb angle have no discomfort whatsoever. So I think that really is a subjective level of severity that's determined by the person living in the body.
That's one thing that I was going to ask you, is that whether they're exercising or not exercising, you are in your body, so you get used to certain patterns, right?
Right.
So you wouldn't necessarily know that down by the lumbar spine or up at the thoracic spine that something is not straight. You've lived in your body for decades. If someone comes to you or someone comes to me, doing that visual check, and we can even just throw out a couple of exercises and see how they sense that, right?
Yeah. Well, and sometimes, like the low back is particularly difficult to see sometimes because the spine is deeper, buried beneath larger muscles. And so what you can look for, and I'm particularly concerned about children, what you can look for is the hip may appear to be higher on one side. The low back may appear to bend forward more on one side than the other. The hips may appear to be rotated forward or back on one side. And then sometimes the person may even think they have a leg length discrepancy that's actually coming from the lumbar scoliosis. So when they lay down on their back, one knee may be higher than the other. And that may not be actually a femur bone difference. It may be driven by scoliosis.
Right. So it would behoove the person who is testing, because I hear this a lot. Someone will come to me and say, oh, my doctor said one leg is shorter. How thorough was that exam to give that kind of diagnosis, right? It might be happening much higher up.
Right. And the clearing for that I always ask is, did your doctor x-ray your femur bones and then measure the femur bones? And if that wasn't done, then I'm not convinced that is actually a leg length discrepancy. Now, I have asked that, and that's been done. And yes, it was a leg length discrepancy. And at that point, it's like, okay, then we're, now we know what we're dealing with.
Right.
Yeah.
One of the questions that has been asked to me is, can playing sports, especially an asymmetrical sport like golf or baseball, softball, can that create scoliosis, or does it just continue in a pattern that's already there, so it worsens opposed to it being developed because you have an asymmetrical sport?
And that's an interesting question. And right now, about 80% of scoliosis is what they call idiopathic. They don't know why it happens. About 20% is due to injury or neurological diseases such as muscular dystrophy or cerebral palsy. And so, but I was just listening to a Mayo Clinic lecture last night given by a spine surgeon, and they were talking about the goal now being more stopping a progression as opposed to fixing a curve, which is great to hear, and that muscle imbalances could in fact be one of the players in progression of scoliosis. Now, can a muscle imbalance cause a scoliosis? As a mom who carried her 3 children on only my right hip for about 10 years, I know that I gave myself a functional scoliosis, which means that it was in my muscles but did not travel permanently to the bones. Exactly. However, bone is a living tissue, so bone will respond to the loads placed on it. Okay, so, I would just say I wouldn't rule it out. However, I would suspect that more sport-specific muscle imbalance, which we see all the time, single-leg sports or triathletes, the bicycling posture, all that.
Yeah.
I would consider that to be more of a functional scoliosis in the muscles as opposed to being structural or in the bones.
That leads me to my next question, which is, do they know if it originated with a genetic disposition or it indeed is environmental because of, for example, what you're speaking of, asymmetrical sports? They don't necessarily know if it's you're born with it or because I've had clients tell me that their doctor said that they were born with it. How would they know that exactly?
So, yeah, well, then there's onsets. So the onsets are birth, puberty, and for women, pregnancy and menopause. Okay, so actually women have more chances than men do. Lucky us. So at birth, if someone's born with scoliosis, it's likely that they're born with a vertebra that was shaped differently. And so that spine is following the shape of the vertebra. That would be one example of, how someone could be born with it. The onsets at puberty.
Because you're constantly growing at that point.
Yeah, and there's a suspicion, there's a theory or hypothesis out there that the brain, because the muscles aren't growing evenly, the brain thinks the muscles are, and then it's pulling
one side.
Right.
Yeah.
And that's actually still in the area of idiopathic. They don't really know, but they're thinking it might be. Then I don't remember what the rest of your question was, though. I'm sorry. What?
Just if they can tell whether or not.
Oh, if they can tell. The genetic thing. There is a genetic link that they're looking at. There's actually a saliva test that's being utilized. It's only utilized for children between the ages of 10 and 12 or 13 right now. And it's not a predictor of scoliosis. What it is it's a more of a predictor, they're hoping, of the progression of scoliosis. So now if a child has scoliosis, they believe that through the saliva test, they can identify these genetic markers to tell whether it's going to really get significance quickly or not.
And do you know when that saliva test actually came about? I've never heard of that.
Within the last 4 years.
That's fascinating.
Isn't that?
Yes.
Yeah.
When you talk about the different stages from birth to puberty, I'm hearing menopause. Mm-hmm. Because our bones are changing again, correct?
Yes.
Because of what's happening in the synovial fluid is diminishing, and we're kind of...
And there's hormonal changes.
And the hormonal changes.
Yeah. Just like when a woman's pregnant, you think you've got relaxin going through the body, the ligaments and the tendons are becoming a little bit more pliable. We have a weight distribution that is different in our bodies. Yeah. So there was a study done 7 or so years ago on postmenopausal women, and they actually found that up to 20% of the postmenopausal women in this study had a lumbar scoliosis that was previously not identified. I don't know if it was not there or not. It was not identified previously, and that's part of the tricky thing about scoliosis, that, when does it come on? I have adults who never knew. And actually, I was going to say one more thing about this. The causes, Thomas Hanna, who, right, somatics, right? Okay, he hypothesized that scoliosis was due to trauma. So I actually have a case of a client who had a lumbar scoliosis that was previously unidentified and was pulled out of a mud hole with a rope around his waist, and that's exactly where his scoliosis is. And there was no other trauma, nothing else had happened. And
is it only physical trauma, or can it also be emotional trauma? Or
see, that's an interesting question, and I don't know.
So trauma, different kinds of trauma play a role.
They could.
Perhaps.
That's what Thomas Hanna was hypothesizing. And in my practice, I've actually had 2 cases where that was a likely cause. Sometimes, the body does what it does. And what I wonder is, it's nice to think that we can find a cause so we could find a solution. Uh-huh. But, someone who already has scoliosis, I'm not really sure that, except for their peace of mind, the importance of that.
Bridging Pilates with scoliosis, have you had success using various types of Pilates moves to either fix or cure, or is there a way to cure something like scoliosis, or we just strengthen the weaker sides so that someone can have an easier life moving through their day? Have you had any kind of client where they started out and they were definitely, whether they knew it or not, there was a lot of imbalance there. And so you did your magic, and you were able to either measure or just notice that they are squarer and bilaterally more solid.
Yes, yes. And I work with children, and I've had curve progression stop and reverse in the children that I've worked with. And when we use terms like cure or fix, it's kind of like
Subjective.
one of my mentors is actually Elise B. Miller from Yoga for Scoliosis, and she likens a scoliosis spine to an oak tree. It's like most of us have a spine that's straight, like a pine tree or a redwood tree, and then a person with scoliosis has a curvy spine like an oak tree, and they're both beautiful and they can both be strong. So it's not necessarily something that needs to be fixed so much as the person is able to stop a progression. Okay?
Because can the progression lead to
Yes.
more severe issues?
Yes.
Such
as if the curve becomes very pronounced, there can be breathing issues, there can be pressure on the internal organs, and women, thinking about pregnancy, how much room is there in the abdominal cavity for a baby? Okay, so it can be very serious. It's not to be taken lightly at all. However, in your question of Pilates and scoliosis and working with people with scoliosis, because Pilates relies on alignment and breath and centering and core control and postural strengthening as its basis, no matter whether you are a contemporary or a classically trained instructor, we're all reaching from the same roots. Okay,
Yes.
Then that is helpful for everybody, and
Yes.
especially for someone with scoliosis, yes. And then also in my work, I am a master scolio Pilates practitioner, and so we use a special system that involves elongation and passive and active derotation for the person with scoliosis. And between the disciplines of Pilates as is and then the addition of specialized techniques for scoliosis, I've seen some remarkable results.
Can you give a brief example of those who are listening, who maybe are teachers or students who have had a long practice? Can you give an example of what that special program is?
Sure. We start out with, of course, you do an assessment so you know what you're working with. And then such an important piece of this is simply elongation. So if you say stretch the spine, what we might call in the physical therapy world distraction, okay, but very, very gently, that gives the person more room to move. And it's more than thinking in terms of exercising the side that is the convexity of the curve, because you can't really think about just exercising one piece of a person. It has to be all together. If you exercise one piece, then often the other section will compensate in the exercise. So using specialized props and wedges to help to derotate the spine and then exercising that person.
That makes sense.
Yes. So we find their optimal alignment for Pilates, and then we utilize Pilates as a tool to strengthen. And I've had remarkable results, as have my colleagues, as I'm sure you have, just finding the alignment. Because so often scoliosis has other things laid upon it. For example, kyphosis, the rounded side of the back. The person will begin to kind of hunch forward on that rounded side more because that's where gravity is taking them. So just working on postural strengthening and alignment can be a huge help that Pilates can bring to a person with scoliosis.
Right. And I'd like to have Gwen back because she's very knowledgeable, as you can hear. And there are lots of other conditions that we Pilates instructors contend with, and not necessarily knowing what is coming through our door. And if anyone out there, a teacher, has a specific question that has not been answered yet, I would love for you to contact me first through my email, which is allthingspilates.kpca@gmail.com. That way I will have the questions, and of course I will pass them on to Gwen. However, if people want to get a hold of you straight away, how would they get a hold of you?
My email, Gwen, Gwen, M stands for Miller, at airportclub.com will be a great way to get a hold of me.
It's been such a pleasure. Is there any parting words for those of us who struggle with scoliosis, or we're just trying to do our due, and any wisdom that you can pass on for all of us?
Sure. Don't lose hope. Just keep up hope. The adult as well as the child with scoliosis can benefit so greatly from skilled help and exercise. It's remarkable how much better that you can feel.
Gwen Miller, she rocks. Thank you so much, Gwen.
Thanks, Darien.
You're very welcome. And for all of you Pilates lovers out there, I'd like to see you again next week. But until then, I want you to lift your head. I want you to lift your spine, because they will lift your spirit. Have a great Thanksgiving, everybody. See you next week.